So when I'm trying to work out which medications I would like to deprescribe, I like to start by working with the patients and finding out their preferences. So if you don't have buy-in from the patient and you don't have their involvement and their consent and their understanding, then the process is pretty much doomed from the start. So it's important that they're with you every step of the way.
And I mean, especially with deprescribing, where people may become very attached to a particular drug that they've been taking for years and years, and they'll often ascribe amazing attributes to that medication. So you've really got to be careful to have their buy-in.
And not just a sort of virtual attachment, but sometimes a physical attachment. So when you deprescribe something too quickly, they'll often get symptoms back and then recommence the drug and therefore have convinced themselves that they can never stop that drug again.
That's true. We often see that effect in reflux medications, for example.
Pain medications as well.
So I like to start with those medications that I think have the least utility in a way, particularly medications that they've been on for quite a long period of time, and there might be other ways particularly to treat that non-pharmacologically, such as sleep hygiene in people with insomnia, for example.
And often monoarthropathy, people taking a systemic non-steroidal for one joint that might be inflamed, or a pain syndrome that you can tackle locally with physio or some sort of local block or topical treatment.
Often the topical treatment they quite like because they're targeting the joint, and the actual massage is good for it as well.
I also like to focus in on those medications that have the least utility for that patient where they are at their stage in their life, and in fact even looking at medications that are quite simply risky, where the risk versus benefit way up has shifted as they've become perhaps more elderly and more frail.
Yeah, it's an ever-changing thing, isn't it? As the patient moves, the risk-benefit curve has to cross somewhere.
And I guess the other thing I sometimes sort of think about is if you're taking a medication more than twice a day, you're very likely to be non-compliant. So things that have complicated regimes would be another thing that I'd be looking at and seeing, can we simplify that, or can we get rid of that particular drug, especially if you're looking at compliance.
Yes.
And luckily, these days, lots of slow-release medications and lots of combination medications, which sometimes have their problems, but at least sometimes they can take 3 things in one tablet sort of thing. So that works.